friends and colleagues. Going over to the topic on interventional cardiology, the case details have already been given. Elderly diabetic male with non-STEMI, low ejection fraction, raised troponins, and a true complex bifurcation, that is Medina 111. And conventionally, yes, all bifurcations one would start with a provisional strategy. But the question is, choosing one stent strategy is always superior over two stent. But the two questions that have been posed: what are the indications where two stent strategy would be mandatory upfront, and what parameters will help in choosing which modality to select? So, without going into a lot of technical details, we know that most bifurcations with side branch disease extent less than 7 to 10 millimeter from the ostium may be managed with provisional stent strategy with one stent. That data has been already well known from EBC main. But what we need to understand is that case selection and strategy selection upfront is important. Reason being that 5 to 20% of provisional strategy may need a second stent in the side branch. It is still possible that close to 8 to 10% of patients it may not be possible to deliver a stent into the side branch, and at times one may lose the side branch or access to the side branch may not be possible. So there are some issues which always will come up in some or the other case in provisional arm as well. And therefore, it is important to understand that not all bifurcation lesions need to start with provisional strategy. And one need to understand which are the complex bifurcations where elective double stent will be important as a starting strategy. So we know from the definition criteria that for apart from the side branch lesion length, which is about more than 7 to 10 millimeter, which will fall into complex, and side branch diameter stenosis more than equal to 70% for left main and more than 90% for non-left main disease, these would be considered as major criteria. And among the minor criteria, more than mild calcification, especially opposite to carina when imaging is done, multiple lesions, thrombus containing lesion, bifurcation angle which is extreme, either less than 45 or more than 70, and multivessel, the main vessel lesion length more than equal to 25 millimeter, indicating overall atherosclerotic burden into the main branch. All these criteria would favor that yes, this patient may require an elective double stent strategy. In the definition study, one major and more than two minor criteria would demand that this patient should be given elective double stent strategy for sure. Additionally, on OCT, if we find that there is carina tip to bifurcation point distance less than 1.8 millimeter, that also would mean that an important side branch could be at a greater risk of being lost during main branch PCI. And all of these patients also, if the side branch is big, even though lesion length may be small at ostium, may need to be salvaged and may have to be considered for an upfront elective double stent strategy. So we know this bifurcation stenting pathways and technique, and the second question was that which strategy to choose. So when we go for elective double stent strategy to start with in Medina 111, based on vessel size and the extent of disease, double kissing double crush technique is supposed to be the most superior. From the DK crush group of studies, DK crush 2, 3, 5, all of them have favored that elective double stent strategy with DKDC is superior to all other modalities, including provisional stenting, in both subgroup of patients, that is left main as well as non-left main. So when we go for elective double stent strategy, yes, double kissing double crush is supposed to be the strategy of choice. Of course, it is technically a little more complex, and operator experience definitely needs to be built up. Apart from the question was about T-TAP and QLOT. So we must understand that T-TAP and QLOT are by and large a strategy which are adopted for optimization of side branch, usually in the provisional arm strategy, and they are not for upfront, by and large, not an upfront bifurcation strategy with elective double stent. Of course, they can be used for optimizing side branch result if we choose to stent main vessel first. But usually it is a side branch first strategy in elective double stent, and there DKDC would be more preferable as a method. T-stenting is preferred when internal angle between main vessel and side branch is 90 degrees, and most often that happens with left mains. It is not suitable for most non-left main or LED diagonal bifurcations. TAP, that is TN protrusion, most often it is for side branch optimization after main vessel stenting in provisional arm. It ensures complete coverage of side branch ostium And to avoid extreme angulation, it is advisable to avoid in acute or wide angle both, because most of what will happen is you will protrude side branch stent much more in the main vessel, and you may have to convert it to either mini culotte or you have to convert it to reverse. And lastly, culotte can be used in all true bifurcation irrespective of angles. It is preferred when both main vessel and side branch diameters are similar, more suitable for left lanes, and to avoid when there is size discrepancy between main vessel and side branch. So I think in the given case scenario with complex case profile, it would be simpler to do provision strategy to start with, because the side branch lesion length, though it is not mentioned, I would believe that it is less than 5, I would still opt for provisional arm and be ready with reverse rush if there is a compromise in the side branch. Thank you.
So I think now we have Dr. Satya Gupta to talk about DEB, the approved therapy for posterior and side branch disease. But 4 more questions, please. Dr. Satya Gupta.
Good afternoon all. Thank you Kamal Bhai and team for inviting for this session. And I congratulate for a nice, wonderful this symposium, which is very crystal. I think most of the people will take very good take-home message now today. So the question here that Dr. Chirag was discussing about this patient, whether we should go for main vessel stenting with versus one stent versus 2 stent. So when this is the patient, like if you see the demography of the patient, is an elderly patient, diabetic, hypertensive, having CKD, GFR almost 40. Sustained non-ST lesion MI, troponin was high, NT-pro-BNP was high, EF was less. So this is a patient which carries a high risk for any kind of procedure. So our aim should be to do a safe procedure in this patient rather than the fancy procedure. So given a scenario, if there is a double vessel, this is a main vessel plus side branch, which is almost 3 millimeter, and the main vessel is 3.5 millimeter. So which strategy we should opt for this patient? So whenever given a choice, when we do a main vessel stenting in the side vessel as a provisional, which is always a good option for a patient which is quite sick and we want to minimize the exposure of the dye, we want to minimize the metal exposure in the vessel. So given a scenario, I think when the patient is very sick, elderly patient, patient with chronic kidney disease, patient with advanced age, diabetic, the results you can give a better with the one stent plus minus side stent, side branch with the drug-eluting balloon. Now, when the drug eluting balloon was not there, that time also we used to do the provisional stenting of the side branch, or we just do with a simple balloon. So, given a choice, I think for elderly patient, critically ill patient, main vessel stenting versus side branch with the drug-eluting balloon is a better option than doing a two stenting with the fancy procedure, complex, which require very complexity, multiple exchange of the wire, multiple exchange of the balloon, and like technically quite skill required in that. So, what are the supporting data for this? Yes, there are multiple studies ongoing, but this is very behind this heart study, university heart study shows that if you compare with the 2 stent versus 1 stent plus drug-eluting balloon, the MACE significantly reduces the target lesion reversal is also significantly less. And the other trial which has been demonstrated, the Asian intervention data suggested that even target lesion reversal and MACE is less if you do one stent and the one side branch you do the drug-eluting balloon. So multiple data now is amazing, and I think in the coming time it will be very clear that for sick patient, very elderly patient with the comorbidity, I think one stent in the main vessel, the side branch can be tackled with the drug-eluting balloon. Now coming the next question, which drug is better, whether paclitaxel or the sirolimus drug-eluting balloon is better? So if you see the difference between these two drugs, the paclitaxel is irreversible drug, while the sirolimus is a reversible drug, and it's a lipophilic. If you see the endothelium or the vessel wall, it's usually it's a wall of the cells of the lipoprotein. So this paclitaxel attached with more efficiently with the vessel cell wall and compared with the sirolimus. And sirolimus is a cytostatic drug. It does not inhibit the replication of the cells, while the paclitaxel is a cytotoxic drug. So it acts right at the M phase of the cell proliferation. So it reduces significantly the cell proliferation, while the sirolimus just a static drug, so it does not reduce the proliferation, but it reduces the size, increase in the size of the cells. So ultimately, if you see the sirolimus just static, but the paclitaxel is just cytotoxic drug. So let luminal loss is more less in the paclitaxel and more in the sirolimus. So now the data available with the you see the transform one RCT data that shows that paclitaxel is better. Let luminal loss is less with the paclitaxel and more with the sirolimus, and late luminal gain is also more with the paclitaxel compared with the sirolimus drug. So given a choice, if patient has a small vessel disease, patient with diabetic, patient with the multiple comorbidity, I think the paclitaxel drug will do a better job than the sirolimus eluting stent. But there are data available for the sirolimus eluting drug also. But because it's a penetration require more, so you need more advanced technology for this preparation of this balloon. So given in the present scenario, the paclitaxel drug balloon is preferred choice in patient with instant resistance because the cytotoxic drug and the bifurcation lesion, especially the high risk patient with the diabetes. So in conclusion, I would say given a choice, stent in the one main vessel and the drug-eluting balloon in the side vessel is always better than doing a fancy procedure with the two stent and putting a stent in the main vessel as well as the side vessel. Thank you so much.
Yeah, Dr. Mukesh Ladda is on the podium because he's also feeling hungry like the rest. He's just going to talk about IVUS. Go to Dr. Ladda, please.
Very good afternoon to all. Now coming to the bifurcation angioplasty with the role of single versus the dual DAS with DAPT, FFR and the role of IVUS in bifurcation angioplasty. We know that our patient is 72, diabetic, hypertensive, CKD and STEMI with LV dysfunction with Medina 111 classification. Now, can IVUS help in deciding whether to go for one stent versus the two stent? This has been explained that mostly we prefer one stent strategy because of the lower procedural complexity, reduced contrast volume, shorter procedure time, and lower risk of stent thrombosis, as well as lower TLR. And this is supported in many RCTs. And mainly the two stent strategy is indicated when there is two bifurcation like this, Medina 111, or large side branches more than 2.5 mm, longer lesion disease more than 10 mm, acute angle were very difficult to assess after the main vessel angioplasty, and the suboptimal results after the main vessel angioplasty, or you get very bad dissection, then you need a two-stent strategy. Now, IVUS guided bifurcation. First, I will do IVUS in both the branch and to assess the plaque burden, MLA and the carina shift risk. If MLA is more than 2.5 mm square and the plaque is less than 50%, then straightforward single stent strategy. If MLA is less than 2.5 and heavily plaque burden, then two stent strategy. And the post PCI IVUS will help in this stent expansion, which should be more than 90% of the reference and no dissection and malapposition. Now, in almost all the major clinical trials on IVUS that shows that mortality benefit as well as long-term outcomes with IVUS bifurcation angioplasty. In main compare, there is IVUS reduced mortality and TLR. In IVUS XPL, IVUS reduced MACE by 48%. In the ultimate trial, it reduces TLR at 2.9% when you do IVUS guided angioplasty compared to 5.4 in angio-guided PTCA. And in DK-5, there is mortality benefit with IVUS. So, IVUS guided angioplasty, it identifies the plaque burden, vessel size, and the carina anatomy with precision. It detects under-expansion in the malposition, improving the stent deployment. It enables the strategy shift from two stent to one stent and reduce the TLR and enhance the procedural success and durability in the long-term safety and reduces the failure rate. Now, coming to the next question, that scoring balloon or cutting balloon is useful in the ostial LCX lesion. We have seen in multiple times when isolated ostial disease, and that time you need not to stand from the LMCA to circumflex. That time the scoring cutting balloon is useful. Basically, cutting balloon, it creates micro dissection in the plaque and improving the lesion compliance and overall reduce the elastic recoil. And after doing a cutting balloon, when you do a DAPT, it improves the drug intake and reduce the need of stenting because of the better preparation and better yield of the blood flow in particular vessel. And pre-dilatation with scoring balloon in small side branches significantly reduce the risk of occlusion after the long stent deployment. So there are supportive evidence in favor of scoring balloon when you use in long stent. It improves the overall chances of provisional stenting and reduce the second bailout stent. Now, if third question is the DEB. If DEB is done in the diagonal and with normal FFR, can one stent be adopted? We know that FFR is very reliable method to identify physiological nature of the vessel. If it is a normal, then there is no significant ischemia, you need not to stent. And so the supporting evidence in favor of the FAME trial has shown that if you do FFR guided angioplasty, there is less number of double stent angioplasty. So in this particular case, if I want to do, then first do FFR in both the vessel, see if there is need a bed preparation, then use scoring balloon. After that, use DAP in the side vessels. If the side vessel is fantastic, then no need to do FFR, even though it goes straightforward main vessel angioplasty like provisional stenting. So in true bifurcation, like Medina 111 with large diagonal, decay curves, Chirag has shown that decay curves has some advantage over other bifurcation angioplasty, and IVUS is essential for pre-PCI assessment and optimization, guiding study selection like first one stent versus the two stent, sizing and the port execution, scoring and cutting balloon at diagonal ostium. We know that ostium is having peculiar fibrotic nature of the disease, and it requires sometimes scoring or cutting balloon to get better result. And FFR post-DAP, if normal, one stent straightforward, safe and effective. Combined use of IVUS, DAP and FFR. It is a personalized physiological guided PCI with improved outcome and reduced TLR. Thank you.